morning, good afternoon, and good evening to you all. And on behalf of ISQua, we are absolutely delighted to welcome you today to today's webinar. We have with us Dr. Francesco Venneri, who will be presenting on the COVID-19 response in Italy, learning from the front line. We're absolutely delighted to have Francesco with us today, and thank you so much for joining us, Francesco. So,
thank you all.
Thank you. Just by way of a quick bio, Dr. Venneri is an emergency trauma surgeon, emergency physician, and a neurosurgeon who is currently working as part of the COVID-19 emergency response team in Tuscany. He graduated from University of Florence Medical School and enrolled in a residency program at New York Medical College, where he was assigned to Our Lady of Mercy Trauma Center in South Bronx from 1991 to 1996. Dr. Francesco trained in patient safety and clinical risk management with a particular interest in clinical audits and morbidity and mortality reviews. In Italy, between 1994 and 1998, he was employed in the Florence Healthcare System 911 Emergency Service and is also medical coordinator of Florence 911 Emergency System. He was then appointed as an emergency surgeon in the Florence Healthcare Service. Since 2002, Francesco has been clinical risk manager of the Central Tuscany Healthcare Trust. So again, thank you, Francesco. Just to explain to our audience today that today's presentation is going to be a little bit different to our usual webinars. Dr. Venneri will not be delivering a slide-based presentation, but will be sharing his first-hand story of fighting the COVID-19 virus on the front line. And then at the end, we'll open it up with a Q&A section, and you can ask any questions that you have. If you do have any questions, then please feel free to ask them in the Q&A box that's at the bottom of your screen, and we'll do our best to get them all answered. So, yeah, let's begin, Francesco. Again, thank you. Where would you like to start?
Well, first of all, I would like to start saying thank you to ISQua for having me invited on this webinar, and I would also like to thank all my colleagues and friends of the Tuscany region, and also the Italian Network for Safety in Healthcare, which is an association of physicians, nurses, and risk manager experts that we initiated as a chapter of ISQua. So I would like to say hello to them and thank you, because at the end of this webinar, I want to, and I'll say it in advance, INSH will, with ISQua, will promote a publication of some recommendations, a document that is going to bring some recommendations on the web, and so it will be available to all first responders and healthcare workers and professionals, or all who are interested in quality and patient safety improvement measures, specifically on dealing with the emergency situation of COVID-19. And so, thank you very much. Well, first, I would like to say that how we handled it. How did we handle this outbreak? It's not easy for me to list a sort of good things and bad things. No, I don't want to do that. I just want to explain how Italy, and in particular how Tuscany, which is the region where I'm working, responded to this emergency. First of all, there was an active response of the emergency system. All emergency departments, 911 apparatus, responded immediately. And then all the emergency department overload was in some way managed, building up external triage filters in order to filter out and to triage the massive people that would come and into the hospital, into the emergency department. Our CEOs and medical directors throughout the whole region, and of course, I believe also in the rest of Italy, had a temporary suspension of the routine elective surgery procedures. We maintained emergency surgery. We maintained oncological surgery, even in a reduced way. Why? Because we needed wards, we needed beds, because this outbreak surprised us, as it is surprising worldwide. And it's so surprising the way that its diffusion goes so rapidly and so immediately. And this is one of the negative aspects of trying to deal with it. And that's why healthcare workers on the front line were surprised and were caught on a non-prepared basis to approach this mass casualty that came about. And it's demonstrating its mass casualty as it is worldwide. The distribution of hospital beds according to specific protocols which are called hospital surge protocols, the way a hospital responds to a mass casualty. We put them into practice. We had an immediate constitution of the crisis unit with appointing spokesmen to speak to the press, to speak to the newspapers, to speak to radios and television. Italy, as in all, responded on a governmental basis. First of all, institutionalizing the Civil Protection Organization and also the National Healthcare Service Observatory. As you can see, every evening at 6 o'clock, we have a press conference, and they furnish data and they furnish update news from the front line and what's happening on a general basis. The recognition of healthcare professionals. We responded trying to identify who should deal with the outbreak and who would have, of course, the major burden of dealing with it. And you can imagine intensivists, ICU therapists, emergency physicians, of course, the frontline workers, and especially many nurses too. An acceleration of newly graduated medical students and nurses. Now we are appointing them on the front line. We had to accelerate their college and nursing school programs and have them become immediate practitioners on the front line. And you can imagine the difficulties that this could break out. And I will talk to that about that later. The involvement, of course, of one of the major, let's say, actors of the healthcare system on a territorial basis, which are the general practitioners. Most of them also lost their lives and got contaminated and were affected by the complications of this COVID-19. Pediatricians, and of course, a prevention basis and prevention measures on a community basis, putting out checkpoints in many of the public facilities. Of course, there are many critical aspects of all this, and I would like to speak about them on a general basis. Of course, I don't want to culprit anyone and say that anyone has the guilty or the rightness of it. First of all, what I would like to underline is the insufficient lack and provision and availability of PPEs, of individual protection equipment, like masks, any type of masks, and the ones that we know actually are the ones that, what masks should be used on the front line, who should use a type of mask, and what type of mask could be reused. This is one of the critical aspects of dealing with this outbreak. Discordant messages. There wasn't any agreement on what messages passed about. We had an overload of ICUs. You can imagine the tragedy that came about when the ICUs used to having work, yes, of course, having a workload. They deal with workload. They deal daily with workload. But you can imagine that used to being 12, 13, 14, 15, 20, 25 beds, they suddenly have the need to open at least 40, 50, 60 beds, and with mechanical ventilators. And this, of course, caused a crisis in the whole system. The lack of drugs, which is now, I had, as a clinical risk manager there, they're reporting me the lack of drugs, propofol, and other myorelaxants that are essential in the maintainment of intensive care therapies, especially with people who need mechanical ventilation. The lack of devices such as non-invasive ventilation or CPAP devices. And the training of young physicians, and I said before that we recruited many young doctors and many young nurses, some of them who graduated really very early, and they've been thrown on the front line, and the problem of training them. And you can't train a professional, a newly graduated professional immediately. He or she doesn't have any experience with all this. And now we are approaching this problem trying to do on-the-job education. It's not easy. It's not easy because mainly time is our enemy. Charlie Chaplin once said this: time is my enemy. And believe me, friends, time is our enemy. The shifts that we had, many of us haven't been seeing our families since about, let's say, 12, 15 days. In Lombardy, many of my colleagues who first approached this grieve emergency and grieve outbreak haven't been home since 2 months. And this means grieving and burdening on their psychological aspects. And this is important. This is important also because we have to think about this for future events. Well, apart the struggle that is on the front line, we have to also deal with psychological burnout. Our healthcare workers on the front line first have a burden on shifts. They're working hours a day, and they don't have any turnovers so easily. Some of us work 8, 10, 12 hours continuously without any type of pause or any type of relief. Some of us remain in the hospital. And then there's also a problem of getting self-contaminated. And I return to the lack of PPEs, of individual protective equipment. There isn't any sufficient number of this. And even if we are having a lot of offers, a lot of production, a lot of industries that are producing it on a very large scale basis, well, they will never be sufficient enough to cover the needs that the PPE should follow. And this is a criticality aspect. This is very critical. And also, frontline workers don't have to chit-chat. We don't need to read long protocols. What the frontline workers want are clear messages, a clear communication. They want to know what to do, when to do it, and how to do it immediately. They can't waste time. We can't look over protocols and procedures which are papers and papers fit. We need immediate, we need clear, we need lean instructions on what to do, when to do it, how to do it, and in the fastest way we can do it. We need help also from the medical device equipment furnitures. We need all of it. We need this because right now we are realizing that we're receiving the outbreak of patients that have been infected 15 or 20 days before, and now we're going to get the curve of implementation in the next few weeks. And so doing the restrictive measures that the government in Italy pronounced recently, having everyone stay at home, be isolated, don't get into any social contact, this would be efficient, but I don't know. Actually, I'm not an expert on this. I only see what's happening on the front line now, and I see that there are, that the coronavirus impact has been underestimated maybe in the future, in the past. I don't want to blame anyone because it's not my culture of blame. I don't want to pick up the blame culture. It's not in my DNA. Being also a risk manager, so I have to see these aspects. Criticality, other criticalities, before going to the lessons that we have to learn up in the future. Communication, contradictory messages, a lack of leadership. Sometimes we don't know who's on the command, who's trying to give us any direction. Teamwork, and this means that if we don't have a clear communication and a clear leadership, we're not going to work good in a team. Decision making and problem solving, they're becoming very critical. Task analysis and management, managing stress and fatigue, which are the problems that we will have to deal with right now, because many of our workers are stressed or have burnout. They need psychological support. Many of them don't see their families since about a month, and so they're worried about it. And some of them, when they receive contradictory information and communication is not clear and linear, they don't know what to do. And so all these non-technical skills have failed in the immediate approach to this mass casualty. And so what lessons could be learned for the future? I'm not a magician, and I don't perform miracles, as I think that no doctor, no nurse performs miracles. Only God can perform miracles. But right now, we have to deal with the problem of burnout and psychological stress, overload, the lack of equipment and drugs, and the need to have clear messages and PPE equipment given to the frontline workers. And what do we learn from all of this? And I think this is the key messages of this webinar that I would like to share with all of you who are listening to me. What are the lessons that we learned or we should learn from this? First of all, when things go back to a routine way, we have to sit down, all of us, sit down around a table and start to put on one column the points of, say, the strengths. On another column, the weaknesses. In another column, the strengths of all this, and in another column, the threats. So to use the aphorism as a SWOT analysis approach, I would say that the lessons that we learned from this are that we need clear communication. Of course, we didn't expect that this outbreak would be of such extension. But being risk managers, and now it's my risk manager that comes out from me being a surgeon and an emergency physician. Being a risk manager, I would say clear communication is important. We have to identify a crisis team and need that only one spokesman be appointed in this team, and only he or she gives the right way to do it. I mean, we need a captain of the ship, the captain of a pilot. We need that. We have need of experts on the scene, infectious disease experts, virologists, immunologists, emergency physicians, intensivists. We need all these professionals. We also need organizational experts on the blunt end. They have to stand behind the scenery and imagine scenarios that could come above. We have to plan the actions and coordinate them on an organizational aspect, on a clinical aspect, on a technological aspect, and let me also say on a psychological aspect. I'm running out of my energy. I'm very fatigued and very stressed about all of this. And what really worries me is how the system could be resilient. We have been resilient, but how long are we going to last? How long is all this going to last? How long it will resist to be resilient? We have to support workers and reduce burnout and other emotional disorders. We have to deal with psychological supports to families of patients and to patients themselves. Many of them are worried. And let me say, hearing from other citizens, we noticed that in the emergency departments, there have been a very low flow of other pathologies. For example, chest pain has people who refer chest pain aren't that numerous in the emergency department now. Why? I'm asking myself, why is all this happening? Why are other common pathologies that in a normal status arrive to the emergency department and overcrowd the emergency department? Why are we not seeing them anymore? It's not that we're not seeing them anymore. It's that people are afraid to go to the emergency department because there has been a very, let's say, alarm message that has come out, maybe a threatful message that came out. Don't go out of your houses. Don't go to the hospital because you might get infected and you might get pneumonia, severe pneumonia, and you might have to get attached to a mechanical ventilator. So what's happening now that many people, many citizens are not really prone to come to the emergency department for other pathologies. Well, we have to have a reflection on this. We have to think about this. A proactive evaluation of protective devices, equipment, and facilities. We have to think that we are vulnerable organizations, and we are vulnerable to this type of enemy. This is an invisible enemy. Viruses, biological microorganisms are invisible. And when your enemy is invisible, you have difficulty in trying to fight it. And you have to have clear protocols, clear messages that might be published and might be given to the frontline workers. We have to furnish lean instruments. No bureaucracy. We're fed up of bureaucracy. We don't need it anymore. It's a failure. And many of our frontline operators and workers don't want to hear any chit-chat anymore. They just want to know what to do, how to do it, and immediately to do it, and how they can protect themselves, because this is a very important question we have to deal with. How are we protecting our workers? Because if we don't protect our workers, if we don't sufficiently protect doctors and nurses on the front line, general practitioners and pediatricians on the front line, they're going to get sick. They're going to get contagious. They are probably going to die also. And if we don't protect them, how can we imagine to protect the population? So, on a proactive approach philosophy and being a clinical risk manager, my suggestion is to involve risk managers more actively in proactive approach. We have to simulate more of these mass casualties scenarios. We have to put simulation into our ordinary work. We have to have our chief of staffs understand that once a month, or let me say even once a week, we have to simulate mass casualty approaches, because otherwise we're not going to be resilient enough to do this. And this is what I am, I want this message to get out to the, to all my colleagues out there, to all my friends out there, and to all healthcare workers. The workers are striving on the front line. They're exhausted, and patients are severely, they are in a severe case, and they need attention. They need equipment. And what we must also understand is that tomorrow, what's going to happen tomorrow when things get normal? If things get normal, how are we going to manage the psychological impact of citizens? How are we going to get back to normal life? We have to understand this. We have to deal with it now. We have to try to understand what to do for tomorrow. We have to do it today, and we can't lose time. And we need help. We need political help. We need governmental help. We need financial help. And we have to be resilient. We have to be proactive before. And Brian, this is what I would like to say to all. I don't know if everyone agrees with what I've said. Of course, it's important that we all share the experiences among ourselves of this very, very grief outbreak of an invisible enemy. Let me last say, before going to have others ask questions, or let me ask questions to others, let me say that a proactive approach is the only way that we can win this battle, win this war, because we're in a war. And in a war, we don't need to chit-chat a lot. We need immediate instructions. We need correct instructions. We need one-line and single-line communication. We need equipment. We need facilities. We need help. We have to be coordinated. And actually, we have to imagine and foresee tragical situations for the future. And I would like to very, very, very thank very much ISQua for having accepted this share of information. I know it may not affect you so much, but I had the need to share with all of you this, because we're reaching the most limited moment in which I think that if we don't do something now and for the future, we're going to get in a bigger crisis than we imagined. And this should be the lessons that we should learn for the future.
Thank you so much, Francesco, for that fantastic presentation. It's very powerful, very moving. I can see a lot of questions coming in at the moment. I can see lots of comments on the chat box as well. Everyone is feeling the same way. I'm actually just going to invite everyone for a minute just to pause for maybe 30 seconds and just kind of really think and let that sink in what you said, and how the lessons we need to learn from this, how we can try and address it going forward. Yeah, I just invite people just to take 30 seconds to reflect on what you just said before we continue.
I would like to ask you, Brian, if you could be my communication expert on asking me the questions, having them ask me the questions. Okay.
No problem. We'll start now. I use that term expert very loosely, I hope. Okay, yeah, well, just again, I just want to say thank you, Francesco, for that incredible presentation. So we'll start off here. Our first question is, I'd like to invite all of our audience to ask their questions in the Q&A panel. If anyone asks questions in the chat box, it can get lost in there because there's a lot of activity in there, so please use the Q&A panel. Our first question is from Dr. Anand James. So what's the role, what's the role of advice regarding hydroxychloroquine as prophylaxis for healthcare workers? Is there any role in this drug?
Mm-hmm. Okay. Yes, we had the message from our experts in the blunt end that this disinfectant could be used to protect ourselves, but also protect hands in hand washing, but also in the surfaces and clean surfaces. Here, let me say that there has been very contradictory information and messages. Some say that it works, some say that it doesn't work. Among experts, I mean. So actually, we had the information that it is supposed to be used for our surface disinfection and protection.
Okay, great, thank you. So with the scarcity of PPE in low resource settings, how would you keep up the morale of our doctors and nurses?
You asked me a very, very difficult question that I cannot easily respond. Many healthcare professionals received contradictory information also on PPEs. For example, these masks that I will show you. You see these masks, these are called medical masks or surgical masks. Well, let me say to you that we had contradictory information. Recently, they said that they could be washed over, sterilized again after 12 or 15-hour use. Can you imagine that if I wear this mask for 12 hours, 15 hours, 16 hours, and I breathe into it, can you imagine that I'm supposed to rewash it again? Well, whoever said this really maybe doesn't know what infection is. And these are contradictory messages. Of course, we need these. We need these. They aren't sufficiently enough because maybe they haven't been sufficiently calculated before an emergency situation. I mean, if we need PPEs, they have to be, we have to predict their use in sense of their number of uses, the number that we need, and for the population that we need. A mask like this, let me say, this is my personal opinion as a surgeon, cannot be reused. It cannot be. I don't know the experts outside if they believe it's the same. Let me say that trying to tell a nurse that's been there for about 18 hours assisting a non-invasive ventilated patient, tell her that she can take this mask and reuse it by sterilizing it with vapor. Well, let me say, we don't have any idea of what sterilization and individual protection means. These are useful. Of course they're useful, and we need many of them. We need many of them for the patients, for the infected patients. They have to put them. Visitors, hospital personnel, they should wear this. But the other protective masks, the one with the valves, which we call FFP2 and FFP3, they are the ones that are supposed to be used for frontline operators, frontline workers who are directly in contact with infective symptomatic patients or patients in intensive care units. It's so, well, that's my idea. I don't think that these could be reused, or you could put them in a washing machine, have them re-washed and given back to the person. Excuse me for being so frank.
That's okay. No, we need, in times like this, we need frank, honest communication, as you said yourself. Our next question is from Isabella. So what do you think the reasons for such a high mortality rate in Italy is, roughly 9% versus 3% elsewhere in the world?
Well, let me say that the patients who were affected, of course, they were mainly elderly patients, of course, with comorbidities. And of course, if a severe infection like this, giving a severe respiratory distress syndrome, affects someone who has a COPD or has other type of, let's say, heart failure or other type of diseases, of course, it could be a little push towards high mortality situation. Of course, this virus affects also young people below 50 years of age, and recently also very young people. It's very aggressive, and the aggressiveness maybe is also due, maybe also due to the fact that it's so contagious, it diffuses so rapidly, and being a droplet and nebulization aerosol type of vehicle, it's vehicled by these means, it's so roughly and so immediately diffused among the population. And probably the high mortality rate is that the patients affected by this, having also comorbidities and maybe cannot reach the hospital or cannot reach the facilities in a sufficient time, or they reach them maybe too late to be treated. Sometimes they told us before that if you have a cough, a slight fever, or some little respiratory distress, you should stay at home and inform your general practitioner. Well, maybe there have been an underestimation of this. What I am very worried about, though, is the problem of nursing homes, which could be where many elderly people live, and these nursing homes are vulnerable to the risk of being infected. And I'm very worried about that population. So I explain to myself the high mortality rate is due to also to the type of aggressiveness of the infection, yes, but also to the fact that many affected patients were elderly patients having comorbidities, and sometimes the inflammatory response of the organism, the immune inflammatory response of the organism, maybe wouldn't be sufficiently captured in time for physicians and for doctors to begin their treatment.
Excellent. Thank you, Francesco. So our next question is from Cecilia. Do you have any evidence to say that the conversion of wards and entire hospitals into COVID facilities is leaving other patients behind?
No, let me say that all hospital workers are, of course, now the problem mainly is COVID-19 positive, affective, symptomatic patients and asymptomatic patients or partially symptomatic patients, of course. No, they're not leaving aside other pathologies. We have an example, a very clear example of how we reduced, of course, medical beds. Internal medical wards have been reduced, of course, but they're still treating patients. We're not underestimating the other common pathologies that come about. No, I can relatively tranquilize everyone and assure everyone that hospitals are dealing with this major emergency situation, but they are continuing to treat other common pathologies that they had. Of course, we reduced our activities, our normal activities. It was necessary to reduce them because otherwise we needed beds, we needed professionals, we needed workers. So we had to, in some way, try and understand. We had to do a self-triage of our services within our services. So no, I could assure people that we're not underestimating, we're not undertreating the other pathologies.
Excellent. Thank you, Francesco. Our next question, you said frontline workers need clear communication as opposed to long protocols, and that there's been a lack of leadership. Could you say a little bit more about this? Whose leadership has been lagging, and what could have been done better in terms of protocols?
Yes, too many people talking. Too many people talking, and sometimes among themselves, among these, let's say, call them team leaders, sometimes they had discordant messages among themselves. For example, I'll give you an example. Recently, someone came and said, okay, these masks are good and should be used on frontline workers who are dealing with affected patients. Okay. The day after, another expert came about and said, oh no, these are not for frontline workers. Frontline workers should use PP2, FFP2, or FFP3 masks. 3 days after, well, these masks should be used for everyone. Patients should be using also these masks. Okay. A week after, patients should use FFP2 or FFP3. And so you can imagine all these messages, these discordant messages. Let me be frank with you. I'm talking on a very linear basis, on a very basement level of speaking, but we can't afford now to have too many team leaders, too many people who want to be expert officials on the front line when we need clear and one-line communication. We need protocols that could be lean. I can show you one of the recent protocols that we received. It's about a 50-page protocol on how to treat an ordinary ward of patients with non-infected patients. 50 pages. What time could I use? When am I going to be able to read 50 pages? What we need are flow charts. Very simple checklists. Flow charts and checklists with clear messages, what to do, when to do it, how to do it, and what I need to do it. That's what I meant with clear communication. Too many people are chit-chatting, and we need people that, be concrete, give us concrete information.
Great, thank you, Francesco. Our next question is from Ilham. The community is panicking after the CNBC report about the virus lingering in the air for several hours. Does everyone need to wear a mask?
Yeah, it's funny enough to say, but no, excuse me for laughing, but for smiling. Yesterday, when I was coming to the hospital, I see many people driving a car with gloves, FFP2 masks, and caps. I started to think about this. First of all, where did they get it? Because we don't have it sufficiently in the hospital. How can ordinary citizens have the possibility of getting FFP3 or FFP2 masks? Okay. What's the sense in wearing masks, gloves, and caps if you're outside? There is no sense. If you use self-protection means and limit contacts, So they told us that we don't have to socialize too much. We have to keep a distance between ourselves. In hospital, workers should wear masks, of course, because we could be, even if not contaminated, we can be contaminated. So I don't believe that wearing masks, gloves, and caps while driving your car should be a correct way to use them. Of course, we have to limit social contact, keep distance among people, try not to socialize too much. The fact that our government ordered to close restaurants, bars, pubs, and all, well, and leaving supermarkets open, I think it's a rationale use of trying to contain socialization. What my question is, how long will it last? How long should it last? And what happens? I'm very concerned about this. What happens, or what will happen after, when the cages are freed, when the people are allowed to go back to their ordinary life habits, if ordinary they will still be?
Excellent, thank you, and very good question. So our next question is from an anonymous person. What is the role of pharmacists in management of public, especially in regard to patient safety?
Oh, pharmacists are doing a very, very unique job. They're doing, let me express my appreciation to pharmacists worldwide. Well, we can call them, we can consider them first responders, because they filter in a certain way the information from the medical aspect and the citizen aspect. So they're doing a very, very honorable job. We need to have more contact with in-hospital pharmacists. And I think that they could be very useful for us on planning how to acquire drugs, how to plan to have drugs furnished on a very, very, very lean way, bypassing bureaucratic procedures. So pharmacists are very important for as first responders. Let's get them back into the hospital. Let's talk about the hospital pharmacists. Hospital pharmacists are very, very important for us clinicians, because they can also ask, and they can also tell us how to behave using disinfectants, using hand gels, using masks themselves. They can also help us on trying to triage, on trying to stratify risk procedures. So I believe they are very strategic professionals in this moment, as they are always in ordinary hospital or ordinary out hospital facilities. They are very strategic right now, and we should valorize their cooperation and keep them into the team that is analyzing the crisis that we're dealing with right now.
Thank you, Francesco. Our next question is from patients in Ghana. So, based on your experience, would you recommend that the authorities are very open on people who have tested positive for the virus, and also in making public aware of recovery rates and the location of the virus?
Information is important. We have to disclosure and be clear and honest of this. And so I recommend that the population should know exactly what the figures are. Data should not be kept into a backstage level. People should know what we're dealing with. Even if we have to be crucial in using some sort of words and languages or expressions, people have to know that we're dealing with an invisible enemy that is so threatful that it could kill, and it will kill. So people should know that when we have positive swab testing performed on the population, and we have the population identified as positive, they should understand how to behave. It's a matter of civil education, civic education. We need this, and we have to, this is another aspect that we should deal with in the future. How to educate future generations to approach mass infection casualties that might reappear again in the future. We had the experience of SARS, of Ebola. Right now we're dealing with some virus that is similar to SARS, that derives from SARS. What's going to happen in the future? So disclosure of data, disclosure of information, be clear with the citizens and the population is a must, and we should do that. And we're obliged to do that also because we pledged to ourselves that as doctors, physicians, as healthcare workers, we pledge to be not to be hypocrite with the population. We should disclose things on a clear way.
Thanks, Francesco. Excellent answer and excellent question as well from patients. I'm just keeping an eye on the clock here, Francesco. I know you have to get back to work soon.
No, thank you. But I'd like to thank my colleagues who are downstairs right now, who are leaving me, who allowed me to leave for about 2 hours. And I'm anxious to get back because I'd like to give them feedback of what we said. Okay.
Of course. Well, we'll take this one last question, then we'll let you get back to your extremely important work. So this final one is from John. What lessons from some of the Asian countries that saw the outbreak earlier than Europe do you think they're transferable to European countries, and what would you recommend?
My personal opinion is that we're all on the same stage. And we need to learn and share information on an exchanging basis. What happened in Southeast Asia, what happened in China, and it's proven to be important for us to share this information, and it must be shared. So we don't have to isolate ourselves and saying that, oh, how good I am, how good I was in approaching this situation. We all need to learn from others, and we shouldn't be we shouldn't be self-appraising ourselves. We should share all information together, because what happened to me could be useful for the US, could be useful for the UK, could be useful for France, Germany, and other words. What happened in China is useful for us. What's happening in South Korea is useful for us, so we should share it. And this, I think, is what the WHO should pursue. This is what we should do in the future. And I would like to launch a suggestion. Future conventions, future quality conferences, future patient safety occasions, workshops, and all should deal with this argument that we're dealing with right now. And I would like that everyone to know that everyone is important. There are no big shots or no inexpert people. We're all on the same ship, and so we have to share each other's experience and each other's information, learning from what went wrong. That's my message that I would like to share with all of you right now. Learn from what went wrong and try not to make mistakes again, as mainly trying not only to save lives, we should cure and care for our people, for ourselves, for our patients, for our facilities. I think that sharing information and sharing it on a very, very community basis is a key of success for the future. But we have to learn from the messages and learn from what went wrong.
Excellent. Thank you, Francesco. I think that's a very fitting final note. A great question and a great response. So thank you so much. Just a reminder to everyone with us here today that the recording of this will be available on the ISQua website, and we invite you to share it with anyone you think you might benefit from it. That'll be much appreciated. This is the first in our COVID series of webinars, so please stay tuned. Keep an eye on the ISQua website for updates, and please join us for all future ones. And just, I'll wrap up quickly now. Sincerest thanks to you, Francesco, for taking the time to present this, to share your lessons learned, and for doing the extremely important and inspirational work that you're doing.
Can I say good luck to all my colleagues on the front line worldwide? Keep up. Don't just grief. I mean, keep on working, and I think I'm sure we're gonna have a success.
That's it. Yeah, so sincerest thanks to you from everyone, on behalf of everyone for ISQua, and I see everyone in the chat here as well. It's nothing but thanks and praise for you, so thank you so much.